Hi, everyone, and welcome. I'm Khurram Nasir, one of the associate editor at Journal of American College of Cardiology, and I am really excited about today's conversation. And we are so pleased to have Dr. Rohan Khera join us, who is the senior author of an important new study that is being simultaneously published in JACC. With their presentation at the American College of Cardiology Young Investigator Award. His team performed a comprehensive pooled analysis using individual participant data from 7 phase 3 randomized trials, all focused on understanding how tirzepatide, a dual GIP GLP-1 receptor agonist, impacts a range of cardiometabolic markers in those with type 2 diabetes. Now, of course, we have seen growing buzz around this incretin-based therapies, especially for their role in weight loss and glycemic control. But this study takes it a step further, evaluating how tirzepatide affects multiple components of metabolic syndrome as well as in totality, and how consistent those benefits are across diverse patient groups. So, Rohan, again, thanks for being here and congratulations on a very timely and impactful study.
Thanks, Khurram, for having me here. Really an honor to be publishing in JACC and especially simultaneously with ACC scientific sessions. Our group is excited about, at least showing both how you could do science at scale and how you could come up with inferences of this nature that can be useful broadly for science and science communication as well.
That's perfect. So, Rohan, let's start at the top. What really motivated this deep dive into tirzepatide's cardiometabolic effect beyond, of course, the glucose control and diabetes, and I would say weight loss? What were the key questions your team wanted to answer that I would say hadn't yet been addressed by the prior SURPASS trials?
Clearly, the major challenge that we all encounter in our practice is that patients often present to you with a range of metabolic abnormalities. And they're often asking, okay, our lipid profile is, did I have abnormalities in my lipid profile, or have a high waist circumference, or my BMI is high, I have sugar problems and blood pressure challenges. And you're often managing many of these conditions simultaneously with a range of different medications. And with the emergence of GLP-1 therapies, there are two things that need to happen. We have to kind of understand the broader effect on cardiometabolic health, and so that we can talk to our patients whether they would gain more from more than just weight loss from these medications, because they're broadly branded as weight loss medicines, but I think their uptake will be promoted by the fact if the patients feel that health markers also improve substantially. So I think that was the major goal here for both clinical communities and patients to identify the range of benefits they could derive from this. And again, if they don't derive benefits, we wanted to see that negative null effect too. So we wanted to just explore this to see what patients would benefit from in terms of their metabolic health.
Well, one of the key things which was really intriguing for me, you had access to, I would say, individual participant data across 7 SURPASS trials, which isn't seen something that we see often in this space. Now, methodologically, again, pulling all these data from these global RCTs is no small task. How did it happen, and how did you handle the differences in the study design, I would say, patient population, background therapies, and still arrive at a consistent, interpretable picture?
Excellent question. I think I'll take on the first question of the logistics of coordinating this. So Vivli is a nonprofit research platform that works with pharmaceutical companies where they can deposit their trial data. The pharmaceutical companies are still the owners. Vivli provides a platform for secure hosting and analysis. They have a very rigorous approach to evaluating studies that are suggested to them. The sponsors of the trials, the pharmaceutical companies, would actually review those proposals and grant access. But once the access is granted, they don't give you the trial data primarily to investigate directly, but the data are housed on this research platform where you have to leverage your expertise in being able to use the platform and being able to conduct all these analysis. So I think our team did the hard task of putting together the logistic task of putting the data together. And after the data are there, they are organized in separate trial units. They're all separate 7 trials data sets. And again, that's where I feel clinicians and clinician scientists have such a major role to play to harmonize the trial elements consistently required you to understand how each element was defined in each trial and how whether you could even combine them appropriately for both covariates and outcomes. So we did that. It does help that it's a randomized clinical trial, so the covariates on average are balanced. But we ensured that that this balance was attained specifically throughout the course of the trial and the analysis, and ensured that all covariates were balanced in all analyses. And we used mixed methods approaches to account for where the patient came from and what kind of covariate distribution they had before we made any conclusions about the effect sizes.
Right. So, that's fantastic. Another thing that methodologically there was, I would say, although it's a meta-analysis, your team performed individual patient data meta-analysis. Now, help us walk through what was the true advantage of doing that versus the traditional meta-analysis? How did it shape the questions you were able to ask? Or more importantly, the granularity you were able to explore compared to working with just aggregate trial results? And how should the cardiovascular community start thinking about these type of analysis in the future?
I think there are many unique benefits. So first, I would say being able to reliably conduct subgroup analysis is a major step in the first place itself. We could choose our own age thresholds and binning, did not have to. And if the trials chose different age thresholds, we were not limited by them. We wanted to do 65 and above and below, we could do that. We wanted to assess baseline SGLT2 inhibitor use as a component of this, we could do that as well. So any of these analyses that you would consider important clinically, you could address them at the patient level and were not constrained by whatever secondary analysis the trials chose to report. Second, I would say the benefit also comes from the fact that we could actually see individual variations. And when the papers, as you would review the paper, you would see many of these plots that we have included in the trial as a part of this work with JACC and the journal, which actually show how some patients who didn't get the treatment arm did actually have large changes in their metabolic profile too, both positive and negative. And it is just the fact it kind of underscores the fact that treatment effects are on average. Not every patient experiences the same benefit. Some benefits are more prominent, and some of the treatment and on average it was way better in the treatment arm versus the standard of care. And but I feel it just demonstrates the heterogeneity of effect that we observe, and actually very useful for people to see and appreciate, especially when they're prescribing these medicines in practice.
No, absolutely. And again, for me, also one of the most striking parts of the paper was the waterfall plots showing these individual responses across the various cardiometabolic outcomes, not just the weight, AH1C, but waist circumference, blood pressure, lipids. So, what was your first impression when you saw the plots for the first time? I can tell you that definitely the degree of variability did surprise me. Clearly, even on those therapies, as you pointed out, not everyone's responding the same. And I would say that aligns a lot what we see in the clinical world. How should the future trials conduct themselves rather than just giving average results? Because the key idea is how can we inform the clinicians, and especially in their interpretation in the spread and response that we see in the real world, but in most of these clinical trials, mostly we are provided with averages.
I think the idea of including plots like this should become a norm, because I think the primary trial is the one that gets the most visibility, and I feel some of these analyses occur way after the primary trial, and that reduces a lot of the inference that somebody can draw from them. So my takeaway from this is it would be nice to have seen these effect chain differences in the primary trial results themselves. So I certainly feel like that will help. And then I think we should start reporting more on proportion of population that demonstrated a thresholded effect more clearly, because even now, even though we demonstrate the waterfall plots, it's a little hard to conceptualize for individuals what that means, especially when I am an individual, where do I plot in the distribution and what effect can I, and again, I think future questions that we want to address are these. Like, how can a person know where do they lie in the spectrum of benefit on different axes? And just demonstrating that for the first time was very helpful to have.
And I think so. It becomes even critically important for therapies which you have difficulty to access and are
Yes.
costly, where actually the true degree of benefit at an individual level should at least be predicted, or at least kind of judged at the start, rather than considering that everyone will have the same impact.
Yeah, I mean, I certainly agree because especially for GLP-1, access is major issue because cost is still high. And if we were able to target those populations that have majority benefit, then I think you have the ability to do that. And in some of our prior work, we have demonstrated that there is the ability to pick up signatures of people who have consistent benefits. So I think this is the first demonstration that there is a need to do that in this large domain as well.
That's perfect. Now, apart from, of course, you highlighted the individual components, but you also focused on the substantial benefit in resolving metabolic syndrome in totality, which is a
Yes.
combination of that. And of course, what we found was a 70% reduction in odds compared to, I would
Yeah.
say, the comparators. But can you talk a little bit more about the absolute benefit that you saw? And among the different components, were there any particular effects that stood out for you, or maybe even challenged your expectations?
I mean, I would say that a lot of these proportion of the population that were enrolled in this trial actually had metabolic syndrome at baseline, as high as 80%. So if you're seeing that high percentage of metabolic syndrome, then certainly like a 70% reduction in that is a massive benefit in terms of odds of having that post treatment. I think the we saw, remarkably, if I had to pick out, I felt that every single outcome we included had like substantial benefit. Like, if you saw just like markers of obesity, like BMI and waist circumference, central adiposity, large 70 to 80% reduction on like at waist circumference, very large effects, visible as well as like metabolic health has improved. We saw 50% reduction in triglyceride level, like people with better triglyceride profile and not being having elevated triglyceride levels. So blood pressure drops. So I think, every axis is favorably affected by very large amounts, like 50 to 80% reduction in odds of these adverse metabolic profiles. And I felt that was remarkable. And it's actually maybe foreshadows, actually highlights the fact that we will in the future see large CBOT benefits. And the trial in our CBOTs, because the cardiovascular outcomes are going to be, again, they are going to have some pleiotropic effects that we believe there are, and will have some effects on cardiovascular outcomes. But these are known risk factors with long-standing history of cardiovascular outcome associations. So I feel like this over time will actually, just like statins, will have that long-term accumulating effect on cardiovascular outcomes that even trials may not will underestimate.
Well, one thing that also caught my eye, that the benefits were more pronounced in younger adults and in those not already on SGLT2 inhibitors. What's your take on that? Do you think it's more of a biology of response signal, or maybe just being on the SGLT2 inhibitors a marker of more advanced disease, or does it suggest there are more, or is it more about room for improvement in this subgroups? Help us walk through that.
I think the fact that we see age level differences were very interesting, and maybe it suggests that there is a little bit of people who survive an older age with obesity, advanced obesity like this, that there is maybe more resistance to responses, like things that traditionally would change to weight loss will not have had an effect, and maybe it's like a less resistant, more the profile is more favorable for those who are under the age of 65. So that, I mean, again, this is all conjecture and speculation on my end, but definitely seems to be a very strong interaction effect too, if you see in our quantitative interaction assessments. Both qualitatively are are improved, but much more remarkably in the young individuals. And I think, you see similar effects in the SGLT2 inhibitor population. And I wonder whether like some of these are collinear with each other. Like there's a benefit of no SGLT2 inhibitor use because there maybe the diabetes profile and other elements are also improved more substantially because they also had GLP-1 as the primary therapy driving the improvements in profiles. So, I mean, certainly that particular axis needs to be further explored, and whether like there is some cross interaction biologically, that probably needs to be explored as well.
So finally, zooming out, how do you see this class of therapeutics fitting into the broader landscape? Now, of course, it is now best used as an anti-diabetic medication, a weight loss agent. Now there is definitely more insights coming around heart failure management, also potentially for sleep apnea. Do you see its role expanding as a true cardiometabolic therapy? And what are the key unanswered questions that we still need to study to fully understand its role?
Perfect. I mean, I think that's a great question to sort of cap off our conversation. The way statins came around for lipid-associated cardiometabolic adverse profiles, I think this is obesity-associated adverse cardiometabolic profiles that we will target with these agents. That may be an outcome associated with heart failure, with sleep apnea, whatever may be the downstream manifestations of obesity-related disease. I think we will see benefits from these agents, and we will. I believe with all this emerging evidence here and in studies with hard clinical endpoints, we will definitely move the field towards a broader adoption of these tools to improve cardiometabolic health and cardiovascular outcomes. I certainly see the need now is to refine who benefits the most, because certainly if we are seeing these large gains, but the gains are not uniform like we have demonstrated in this, the way we target therapy is going to be critical. And it's a bane of like our entire like risk primary prevention and prevention in general is the idea, population treatment versus personalized treatment, and that interplay will become even more critical with therapies like this.
It's perfect. So, Rohan, this was terrific. And then again, thanks for taking the time to walk us through the science, I would say the practical insights and also the broader implications. And I truly enjoyed working on this paper. What your team has done really helps us guide, eventually, I think, bridge the gap between efficacy and implementation. Especially as we rethink, as you pointed out, how we define who are likely going to benefit the most and how we treat the cardiometabolic risk portfolio. So I'll be definitely be watching very carefully where this field goes next, and truly appreciate your leadership in moving it forward. And then again, if you have any final message for us.
No, I think the final thing I would say is that thanks to JACC and the editors and you, Khurram, for spearheading this study, giving us feedback on the shortest time turnaround I've ever seen possible, and being collegial and collaborative. And I think that's full marks to JACC as a journal and for a venue to publish our science. Thank you.
Perfect. Thank you so much.